What's that?
Death.
One more time.
Death of the.
Death, cardiac arrest, usually is like there's no. That's my power went out.
What about perfusion?
Perfusion. So cardiac arrest, you know how you've heard with the heart, there's a plumbing side and there's electrical side. So cardiac arrest is when the electrical side is shut down. And that's when we learn that the ACLS and the shocking is really going to work. Now myocardial infarctions can lead to cardiac arrest, and especially if they're severe. And cardiac arrest can be caused by myocardial infarctions. But cardiac arrest is the electrical part, so the ones that start in the SA nodes and the AV nodes and go down the Purkinje fires. That is when that is not working, it's been interrupted. Where myocardial infarction is the arteries that feed the outside of the muscle of the heart has been blocked, whether by blood clot or plaque or air or whatever else, but it has been blocked. And then a STEMI is when those arteries are completely blocked and that we have no flow down the artery at all. Things that cause this, we probably know this, and the number one reason is family history of it. So you can't really change that. But the reason why we go over this is because if somebody says their dad had a heart attack before the age of 65, then it leads you down that pathway. Yeah, he could be one of those ones, even though we don't know for sure at this EKG, but you need to start to think that it could be cardiac related. And any of these, and there's a couple things that I didn't include in this. Another one that we're seeing typically, and our cardiologist has agreed, of course, COVID, we saw more clotting. And so we had a lot more full clots going on, not just cholesterol buildup. And then also testosterone increases the clotting and the thickness of the blood. So we see a little bit more blood clots with that. And then, of course, I didn't also have on here drugs, street drugs will cause a clot in there and can shut that down. So besides these, and the reason why, I'm sure all of these are very typical and it can lead you down many pathways of what it could be. But when you hear that they have all of these things, hopefully that the pathway you're thinking about is cardiac or ACS there. So when they have the classic symptoms, as you will know, our most classic symptom is chest pain. Typically, chest pain isn't related to a pinpoint area of the heart or the chest. It's more radiant. It's so radiant that it's going down into the arm, the back, the neck, the jaw. It's like everywhere. If they're saying that it's pinpoint, you can't absolutely rule it out, but you can also think that it could be more down the indigestion or abdominal pain from that. And again, if below the xiphoid and into the lower extremities, you can also rule out that it would not be cardiac there. As a heart attack, and you guys with experience would know this, progresses, we start to see some of these later symptoms. What are some later symptoms that you typically see if you're in a heart attack that is down the road, down towards death a little bit more? What are your classic later symptoms that you see? You with experience.
Could be low stats, right?
For sure, because you're not getting oxygenated blood to anywhere. And in that sense, that's one of the reasons why we want that reperfusion really fast, is because you're not getting oxygenated blood to the heart or the brain. When we go into a heart attack, when I come in because I've been called in for a STEMI, I always want to look at the patient, because by the looks of the patient, I can tell kind of how far it progressed. Now, obviously, if they're getting intubated, they're in serious trouble, or they're intubated, they're in serious trouble. But some other symptoms that I've noticed as it progresses, a heart attack is that's when they start to get really diaphoretic and that gray and that palish gray look to them. And then, like you guys probably recognize from the streets, like that's when the patient is going to crash on you, and you know what, and that nausea starts in. If we have a patient on the table, they're having a heart attack, it could be a STEMI, and all of a sudden they start to say their nausea, we can about shoot dang that are going to crash on us pretty darn soon. So those are kind of some things to keep in mind that you might be able to recognize, like, oh, this is getting worse, we're getting close to having a cardiac arrest or here. So it is time dependent, and you guys are a big part of that time dependent disciplinary team. Do you guys know how long we want to shoot for by the time you hit the patient to reperfusion? What does that clock say, the national average say we have to be
Is it 90 minutes?
90 minutes, perfect. That is the national average, and that clock starts from the time that you guys say you have arrived at that scene, and that's when that clock starts. So it is 90 minutes. This is all reported by every hospital on every STEMI case that has to be reported. You have to keep 80% above that 90 minutes. 90 minutes goes fast. Usually when you guys are involved, and this is what I teach the public, it usually cuts out 15 to 20 minutes. Because you can always, as you well know, you can activate the cardiologist and us, and we have time to set up the tables while you guys are bringing the patient in, which really does save us 15 to 20 minutes on that. Now it becomes time dependent because you can see how our muscle dies on this picture. So these are our ventricles. That is your right ventricle, and this is your left ventricle, and this is the muscle that surrounds it. So you can see as a progression, and right between that first and second hour, how much more depth of that heart muscle is when we get there. And so that's how they have determined that 90 minutes is the key to try and get that done in. We at Davis Hospital we try to be as good, I'm sure everybody, like you guys, everybody, we always want successful stories. So luckily we have been able to, never had a problem with not making those 90-minute involving the EMS. So we are very thankful for your support and help there. And also, just so you know, if we were not a PCI, which means percutaneous intervention, which is a heart and stent, then we have to get them out of the hospital within 30 minutes with some fibrinolytics on board. And then, like I said, the EMS is 90 minutes, door to balloon is 90 minutes, and then if they come from a second facility, so either Layton or a doctor's office or the Roy, then it goes up to 120 minutes that we have to get that there. So the interesting thing is that we go over all of these chest pain symptoms of a patient, but realistically only 54% of those patients come in with those classic symptoms. And that's why we want to look at those risk factors to see if these patients could possibly be a heart attack patient. Some of those reasons, or some of those population that doesn't always come in with the classic symptoms, is, let's start with a diabetic, that first picture. Why would a diabetic not feel the classic chest pain, possibly? Can you think of any reason why a diabetic would not feel classic chest pain? You know, most of you know, like as people have diabetes that's not in control, they start to have neuropathy. What is neuropathy caused by?
Poor perfusion.
Poor perfusion, right? So again, poor perfusion, and it's death of the nerve cells. So when diabetics don't control their blood sugars, they get poor perfusion and it causes the nerves to die. So they may not come in with classic chest pain because they don't feel that pain anymore. Just like they don't feel their feet anymore, that from the neuropathy, they don't feel that chest pain. So a lot of times they might come in with more fatigue, palpitations, nausea, vomiting, something a little more like that. Men, as they get older, they typically don't come in as much with chest pain as, again, more about palpitations. And women also often can have right-sided heart chest pain, and they can feel a little bit more lingering doom and not as clear-cut as symptoms for that chest pain there. I just wanted to go over this. I kind of wondered about putting this slide in or taking this slide out for you guys, but I thought it was pretty important. There's 5 emergency diagnoses that can have that chest pain that is not a heart attack. So sometimes it's kind of nice to have those just in the back of your brain. And those include an aortic dissection. If you were to have an aortic dissection, it's pretty life-threatening, obviously. And does anybody know might be a more classic symptom than just chest pain that if somebody was having an aortic dissection?
Pulses or blood pressure will be different?
Yeah, blood pressure is probably different. But I heard somebody say back pain. They're going to have a lot more back pain than a chest pain would typically have, and it would be a little bit lower if they had an aortic dissection. Pneumothorax, pulmonary embolism, pericardial effusion. You know, every time I see a possible PE, or they're bringing them in because we fix PEs too, right? I always look for that defining blue line that goes across their chest, or if they're more blue in the upper, in their head area, to see if it's related to that. And not esophageal rupture. Have you guys seen that? Has anybody seen theirs? Esophageal, oh, it's not pretty. if there's esophageal rupture, they bleed out and bleed out and bleed out, and that's not fun. And so hopefully, but they couldn't have chest pain with that. So we're gonna go into some EKG practice here, and probably know this, but I just wanna make sure it's always good to review. EKGs are easy to read if you read them every day. And you guys maybe read your 12 lead EKGs, but it's something you have to keep on and practice and review. But we're just gonna go ahead and review a little bit more of it. So this line here, remember that this, I'm not used to the point where I like, is the timing, right? And this is the volts or how high it is. So when we're talking ST elevation, you're going how high, right? Because it's going to be the height where this is the time there. And you know, like, I don't necessarily care. I mean, obviously, YQRS is always something that we consider that could be concerning in any situation. But 0.2 seconds is the big squares, and 0.2 seconds is like the full 5 squares. And so it's just showing those. Do you guys know that, right? That's kind of basic. This is kind of basic, but I want to make sure that you know. So a Q wave is the first negative deflection back to baseline. Why else would, they're often not seen in the QRSs, but particularly with heart attacks, we do look for those that Q wave. Does anybody know why? So after, about 80% of people after they have a heart attack get a Q wave. So it will mean that they have had an old heart attack, and it usually comes in within the first 24 hours. And some people's go away and some people's never go away. So on the top where it reads out the 12 lead EKG, if it says probably an old infarction, it's because there's a Q wave that it has picked up on. So that's one reason why we may be able to see. And also so that can help to identify if somebody said they've had chest pain for 3 days and now they're calling EMS and now they're having a heart attack. If they have a Q wave, yeah, that event probably happened 3 days ago, and you can see that happened. And then the R wave is the first positive deflection, the S wave is the first negative deflection. The J point is super important in identifying heart attacks and STEMI. So I put that on there. I know that we don't go over all the time, but that is exactly where we look to see if that is elevated, to see if it's ST elevation, and it is that having that J point going into the ST program. Now, if you went to nursing school or EMS school or paramedic school or whatever you did, they used to tell us that to look at that ST elevation, go off of the PR interval right there. But now they're finding more consistency if we see that ST elevation going off of the TP, so after the T wave, and that calls that TP as being the baseline there. So that's kind of, and I kind of look at that because that's my job, is to look at things. And I see it to be a little bit more accurate to come off of that TP segment instead of the PR segment there. So we're going to start practicing a little bit on this first QRS. Right here is the J point. If it's below the baseline, then what do we call it?
Depression.
ST depression. So what's important about ST depression?
Could be what?
Tells you there's elevation somewhere else.
Because there could be elevation somewhere else, so it can be the reciprocal changes of another ST elevation. It can mean that there's concerns, and it is kind of the precursor, the first step into heart damage is you'll get ST depression, and then it will go to elevation too. So those are great reasons. On the second picture, you can see here is the ST elevation, and here is the P. And we know that one, you only need one small block to cause it a STEMI. And I don't even have to count them because I can eyeball that and see that it's ST elevation, and that's a STEMI QRS code. And again, here it's not as clear, but you can determine that this is below the line and this would be ST depression. This is how our ST QRSs kind of emerge. Like I said, a lot of times we'll see ST elevation, and then you'll see T wave, peaking T waves. So you can see here, and they inverted the T waves. This is the point that we see on C. This is our point that you see ST elevation and STEMI. These are just pre-STEMI elevation, and then you can see that you have that negative Q wave there. So when you're reading 12 lead EKGs, it's can be difficult sometimes, and like I said, the more you do it, the more you're able to do it. But I'd like you to think of the heart, and this is, of course, the aorta comes across, and these are the arteries that come over. This one here is the RCA, right here, and it starts to wrap around the back. This is the LAD, some people call that the widowmaker, and this is the left circumflex, and it wraps around and meets it in the back also. When we're looking at 12-lead EKGs here, we're looking for that area, and we are looking for combinations of the area to call it a STEMI. So it's taking literally this area and placing it up here and taking a look. So this is lead 1, you can see this is pink, it's lateral. Lead 2, you can see it's green, it's 2 and 3. So if I have elevation in that 2 and 3 in AVF, it's an inferior area of the heart, and it's going over the RCA, so it's the right coronary artery. Now some of you guys are knowing, why is it important to pick out if they're having elevation in 2, 3 in AVF? Why do we want to know that?
For nitro.
Because of the nitroglycerin, right? So that area of the heart, the right atrium, right ventricle, is dependent upon fluids to be able to move the fluids through the heart. It's very fluid or preload heavy. It likes preload. To get preload, you need fluids. So when we give nitroglycerin, it dilates those arteries. And as we dilate their arteries, you're going to have less volume in it. And so that decreases the preload. And that is why we don't give the nitroglycerin there. You can see here, and I kind of cleave V1, V2 in the LAD. You can see the septal area is right here, is the purple area. And then the anterior part of the heart is right there, which is the LAD. So in the V leads, it's V1, V2, 3, 4. And then lateral is the pink, and like I said, it wraps around in the back and comes here to the front. So some hints that I learned to remember the areas, because you need you have to have elevation in 2 of the areas that are color coded to call it a STEMI. So inferior, do you guys know any hints to remember inferior, what leads it includes an inferior STEMI? 2, 3 AVF. So inferior has the F. So I always remember 2, 3 and AVF. Inferior, 2, 3 and AVF. And the inferior part of it is where the right coronary artery is. 2, 3 AVS. Now luckily, lateral obviously means in a circular, and it has AVL in it. So 1 AVL, 5 and 6. So now you know it's the left circumflex artery. So your lateral artery, which is the left circumflex is round, lateral is round, has 1 AVL, 5 and 6. And then the septal is the V ones, 1, 2, 3, 4, straight down the front of the heart where we have the LAD. Now my cardiologists say that only truly the left main, which is right here before where the circ, right here before the circ and the LAD break off, is the left main. That is truly the widowmaker, and indeed if your left main is down, you would be a widow. But most people in the public, and even most primary care doctors, anything in your LAD down the front of the heart, they do that because if you put the chambers of your heart in the right area, what chamber is the LAD feeding? The left ventricle. The left ventricle is known as the pumping chamber because it pumps all the oxygenated blood. It's the last chamber that pumps it out to the aorta, which delivers it to the body, to the brain and the heart, and then the rest of the body. So if that's not working, then it's more likely that you will have a poor outcome with that. So that's why they call it the widowmaker. Like I said, it needs to happen, and this is just different color coded, but it's the same map as we had on before. To call it a STEMI, it needs to be elevation in 2 of the areas that have the same coloring. So you really need to remember 2, 3 in AVF is inferior, 1 AVL, 5 and 6 are lateral, and then B's are the LAD there. So here, kind of just going in here, here's our normal EKG. So you can see lead 1, lateral is right here, and 2 is right here. You can see that here is right along the baseline. It's on the exact same dotted. And then you can see your V leads are V1, V2, V3, V4, and then your lateral there. So next practice. So when I look at an EKG now, mind you, I am looking for heart attacks, okay? I'm not looking particular for AFib, and I'm not looking particularly for BTAC at this point. I am just looking to see if we're having a heart attack. So when I look at a 12-lead EKG, I'm looking for ST elevation. So I glance at that EKG and say, what looks possible? And then I group it to the area of leads that we need to see 2 of them elevated in. So if I asked you what looks possible of ST elevation, what lead would you guys say?
3 ABF.
2, 3, and AVF, right? And that is the inferior, right? 2, 3, and it has the it's right color coded. And so what coronary artery might possibly be down? The RCA. And that's where we don't want to give that nitroglycerin. Now something I just read most recently in some article is if we see progression in the 2, 3 and AVF, it's getting bigger and bigger and bigger and bigger, that it leans it more towards the back part of the heart where the RCA and the lateral arteries meet, and it leans towards more the lateral artery. So even though we may see that we have inferior elevation, if we shoot and it's not elevated, we're going to go to the circumflex next because we know that they intertwine there. And you see here also down in reciprocal leads, which means in the opposite leads, you can see some ST depression in V2. A couple of those going in V2. I think we kind of ran over here. Here's a practice EKG. Oops. Here's a practice EKG. On the top one here is your ST elevation, there is your J point, you can see it's well above it. Then I would say what leads go with it, and I think 2, 3 and AVF, so you'll look at that. It most certainly looks at it. If somebody else said, oh, that looked funny, that's ST depression, that's the reciprocal leads. Possibly these here looks a little bit elevated, so if somebody sees that, if somebody has coronary artery disease in one vessel artery, can they also have it in another artery? Absolutely. Or else would they maybe get disease plaque buildup, which would be detrimental if they build up with accumulation of plaque. Where else could it be detrimental?
Carotids.
In their brain. I saw somebody point to it. In your brain, right? That's a stroke. And that's when also they come into the cath lab. And interesting enough, whether it is a heart attack or a brain, it's very similar in how we go up with the same process. We use the same sheaths, we go up the same wires, we put another longer sheet guide in it, and we go in there and we kind of stand it. So it's kind of that same process there. And the bottom one again, did you guys are able to pick up the ST elevation in the bottom one? Here, there's your J point and your ST elevation in 2, 3 AVF, inferior here. So what's your first immediate care? What do you guys do when you get to there? To the patient, right? If they said they're coming in for chest pain, so you kind of have that on your brain. When you get there, what do you do?
Take a radial pulse.
A radial pulse to see if they have a pulse.
Start. Also checks like skin condition, stuff like that too.
Okay, perfect. And then what do you guys do?
History.
A history. Okay. See what they're, what they might show, what symptoms they may have, what risk factors they have, what are they taking. Okay, great. And then what do you guys do? Then you get an EKG. Do you guys typically do a 12-lead right off, or do you guys do a 3-lead?
3-lead first.
3-lead first. And obviously, if you're doing a 3-lead, we're only seeing 3 leads, right? So it could be in lead 4, 5, and 6, and we may not see it. And that's why we really want to encourage you to get a 12-lead if they're symptomatic of a chest pain, is you could actually miss having a heart attack in a different vessel or in the end parts of the vessel that would not show in that 3-lead. So if they're classic symptom, obviously you guys have to make some clinical decisions on your patients, right? And so if they don't have classic symptoms, then it could be anxiety or it could be other things, you might want to just stop at the 3-lead. But we cannot identify STEMI without that 12-lead in there. So the more quickly that we can get that 12-lead, the better for us. So we're hoping that our goal has always been to get that 12-lead within the first 5 minutes. Now I've been noticing, because I review every STEMI and kind of drill down and get times and everything like that and give them to Jalen. I have been noticing, particularly with the latent group, that you've been loading and then doing EKGs on the way. Is that kind of what you guys, 12 leads on the way?
Yes.
I feel like that's what I've been seeing from you, and I think that's great. Like, we'll deal with that. You know, you guys are usually so quick to get there, and you know it's a heart attack. You want to load and get on your way. Perfect. Get it transmitted since you do. Give us a call. Let us know it's a STEMI. So, like, although I was like, my goal for this year was like to make sure all 12 leads were transmitted within 10 minutes, which is still our goal. Like, if you guys are particular doing now that you're getting your 3 leads, you identify it looks like a STEMI, and you're getting them loaded in a way, then that's very acceptable because it helps us too. Obviously, we used to call it MONA, so morphine, oxygen, nitroglycerin, and aspirin. Obviously, aspirin is super important. Chew it up and get it down. And sometimes we now go away from morphine, although it decreases myocardial demand, so we still like it. But why would we get away from morphine?
The nausea it causes.
Because it's a healthy, dirty drug.
Exactly. Nausea, respiratory depression,
Leaky vessels.
and what?
Leaky vessels.
And leaky vessels.
Preload.
Yeah. Yeah. So sometimes I don't know, in the hospital we use fentanyl if they're really in a lot of pain, and we're trying to get them out of pain just for those reasons there. What kind of arrhythmias do you guys prepare for?
All of them.
All of them? How do you prepare?
Oxygen,
Oxygen.
patches.
So I read your patches, that's always good. So I read your EMS requirements for ACS, and it says that you have oxygen to oxygenate at anything less than 92%? Is that what I've taught? No, that's mine. Anything less than 94. They have found the latest study for ACS that we do not need to oxygenate anything less than 90% for the heart. I know that's not the same as the brain, so like do what yours says, but
Bring
if
them
there's
in
any
normoxic,
conflict.
that's the key.
What's that?
Bring them in normoxic.
Yeah,
Normoxic.
right, and I'm in the opinion still, like, we don't want them at 100% because we could be over-oxygenated, but sometimes it just helps them to relax too, like to just breathe better. So I like the oxygenator, but that is what they have. When that RCA is out, like I said, it's over the SA and AV node. So if that area of the heart is not working, what are you more likely to have if that RCA is down? And the SA node and the AV node? Do you know?
Bradycardia, slower.
Glad you knew that. I was like, maybe you guys, I don't know. Right. The SNA starts the electrical system at a heart rate from 40 to 60. If it's down, then the AV node kicks it in. And if it's down, then the ventricle node kicks it in. So if the SA node, the RCA, is down, you're going to have to prepare more for bradycardia. So much so that if we have a right coronary artery, we have a kit with atropine in it and pacing. Because we prepared for that. That we're going to shut that down when we get that balloon in, and we're going to see more bradycardia. And then at the flip side, if it is a LAD, you'll more typically see a little bit more of those tachycardias. I think this is self-explanatory. It's everything that you do. Like I said, American Heart Association says the SpO2 greater than 90%. Some things that we could do is monitor at all times, repeat the EKGs. If the first one didn't show it, it could be just and it could develop more into a STEMI. Closed remove, I put this on here, but I understand they're buckled in. You may not be able to get those clothes off until you unbuckle. So if you can, we're going to have all the clothes removed below the waist and be able to get to the arm too. That's great, but I understand. 20 gauge, with the left AC and the right AC, we have all right-handed doctors now, and we always stand on the right side of the table. So instead of having to reach over the whole time, they always access on that right wrist. It will be the first choice of access. So if we can avoid below that arm, because we're going to have to put a tight band on that too, and so if you can below the right and a cube. So if you can't get access on the left, but you have a great right and a cube, that would still just be just fine there. So here we're going to go over just some more practice. You guys want to watch? A practice, so if you were to look at this, where do you see ST elevation? 2-3 in AVF. Now that is our most common elevation area of the heart, and that's why we practice that a lot. Do you see any ST elevation anywhere else? Anterior lateral, yep. Okay, so in these inferior heart attacks, it is more prominent to do a right-sided EKG, and I've seen like one doctor once ask for him, but it is part of my protocol that we have the option to do right-sided EKGs for inferior heart attacks. It's literally taking all of your V leads that go across the chest and flipping them to this side. So now you know how to do a right-sided heart EKG if a doctor asks you. Simple Simon. When you do that, you will get these last three, and they should have elevation. If it's not, it would not be inferior, it would be a lateral heart attack there.
Are you seeing, I've heard rumors, or I've heard old stories that you'll never get good pressures with an inferior MI?
Right, you might not get good pressures, right, again, because it needs a lot of volume there, and so if you give nitrogen, you're gonna knock out their pressures, and we do see a lot lower pressures with our RCAs. Did I answer your question? Dan, go ahead, where do you see ST elevation on these? Anything look unusual? Where would you say you'd see an ST elevation? Okay, well, let's take a look at it. You guys may, I didn't hear it. So to me, this is the one that looked the craziest to me. Right there is the change, the J point, and there is my baseline, so you can see very easily that it's 8 boxes of ST elevation. So if I have V2, where else am I gonna look to see if there's elevation to call it a STEMI? V3. And it's kind of funny, it looks like a little bit of a bundle branch block there. But again, I would say this is the J point, and I would say yes, here's a J point. That baseline is really weird. So if you go down to this baseline, that would be hard to identify. I'd be like, it looks like it, but let's have a cardiologist look at that. You know, and then here is your J point, and you can see here it's a 1 box of elevation, so you could indeed call it off of those two. When it's V1, V2, you're going to be more proximal in that LAD, which is a little bit more dangerous because more of your heart is not being perfused there. On this one, where do you see the elevation? Septum. So again, I see when, and there's not an absolute right because it's just what your eyes see. But when I'm looking for a heart attack, again, in that V2, V3, V1 is the easier way. So the septal anterior lateral areas, V1, V2, V3. So you can see there's the J point. It's well more than 1 dot above. Here's the J point, well, when we're above. There's the J point or the notch. And it's definitely more than 1 little dot above there. Okay, another practice, what would you say? Lateral. So lateral, I like that. So here's your J point. What goes with 1 if I do 1? Well, which one am I going to look at next? What lead? AVL. And you can see AVL, so you can call it STEMI, but I'm going to glance over here. And that doesn't look too happy either, even though it's hard to identify. That's probably okay. It still has the requirement of 2 in the same category, so you can call that. Here is a little questionable also to me. You got a J point here. It's definitely above it, right there. So you're going to see some elevation that right there to right there. It's not a full box there. So again, a practice. What is this one? Lateral. High lateral. The high lateral. Yeah. We're going to go ahead, and this is the cath lab team. This is the time we took our last picture. So a lot of these cath lab members are gone, but this is Davis Hospital's cath lab team member at this point. And this YouTube is just 2 minutes long, but it goes over what we do. Now I know who's by raise of hand, who's had the opportunity to watch the cases during the cath lab procedure. Okay, so most of you. It's 2 minutes, so we'll go over that and let you watch it in case you haven't. But you're always welcome to stay in the cath lab then I think we have some case reviews after this. Okay,
You'll need to
so-
go do it on your laptop.
Okay. Oops, no, yeah, no worries, just click on the link.
Just hit the link. Ron.
Coronary angioplasty, also called as the percutaneous transluminal or balloon angioplasty, is a treatment procedure to restore the blood flow.
I'm seeing it.
There is.
I tried to speed it up too to see how I would make myself long.
It's this one here.
Flow.
There we go.
In the narrowed or blocked coronary arteries caused due to plaques or blood clots. Most coronary angioplasty procedures last between 30 minutes to 3 hours. Once the patient is admitted, his heart is monitored and is given an intravenous sedative to relax the body. A needle is inserted through the wrist into the radial artery. A guide wire is then passed through the needle and is guided through the arterial system up to the heart. A flexible catheter is slipped over the wire and threaded up to the heart. This is monitored using a continuous X-ray imaging device called fluoroscope. At this point, the guide wire is removed and the tip of catheter is positioned to enter the coronary artery. A special dye is injected which allows the fluoroscope to take X-ray images of the arterial interiors and help in identifying the position of the block. This is called angiogram. Once the blockage is identified, a flexible guide wire is inserted into the artery vessel, followed by a balloon-tipped catheter over this wire to position itself at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, re-establishing the flow of blood in the artery. After the blocked vessel is reopened, the deflated balloon catheter is withdrawn from the artery. The same treatment procedure is repeated in the case of multiple blockages. Most patients may also receive a coronary stent, which is a small tube made of wire mesh designed to keep the artery open once it has been treated. A collapsed stent is placed over the deflated balloon catheter as it is inserted into position. When the balloon is inflated, the stent expands and locks itself into place. The deflated balloon and catheter are withdrawn, leaving the stent behind to hold the artery open permanently. Post-treatment, a pressure bandage is applied over the radial artery to prevent bleeding. One will need to lie down for several hours, during which signs of bleeding or chest pain will be monitored. The patient may either be discharged on the same day or after an overnight stay at the hospital.
All right. Any questions or any thoughts about that? That's pretty much what you guys see. Arteries, obviously we have the big, it looks like a C-arm, and it takes images from the bottom to the top of the coronary arteries. And you can see our lights go out when you take the images, so it's not that there's a malfunction, it's actually, that's when it's taking the pictures, that's when you get the x-rays. And then you can see that we move those images, so it's looking at the heart from this way, this way, this way, and then we'll come over to the side, look at this way, and this way, so we can see area. It is just, heart attacks are just seen visually. And so it's kind of great because it really involves us as a cath lab team with the doctors, because they learn to trust our eyes as much as they see ours. And of course the heart is pumping and we want to see it within 1 or 2 beats of the heart, where that area is. And so they really trust our eyes as much as theirs. This is typically a typical image of the left coronary arteries. So you can see here, that is my flexible tube that is entering into the cusp. Here you can see a little bit below back of dye, but that's not a big deal. So it's in here. So this artery right here goes all the way to the tip of the heart. Which artery do you feel like that might be?
LED.
LAD. Perfect. Off of the LAD, we also have some arteries that we may stent. You might hear we stented. Off of this side here, they're called diagonals, and they can be almost as big as that LAD, and they'll feed that area of that heart. His second diagonal will not be it. Anything proximal, that looks like it's coming off that side of that heart too. This one here are the septals. It's going down into the middle of the heart. We typically don't stent them. Our smallest stent is about the size of that coronary catheter here. So we kind of visualize that, doctor, what size is that coronary artery versus what size that catheter is. We know that catheter is 2.2 millimeters, and then we can decide how much it is. So something smaller, like this one here, you can see what's smaller. We probably wouldn't stent it if it was down because it's smaller than that catheter and would have an increased risk of dissecting that artery if they're not big enough.
While you're on that picture, could you maybe tell everybody about collateral circulation, collateral flow, and what it might look like, or maybe?
For sure, I should take a picture. That's a good idea. And I'll add a picture for next time because that is an important thing. So luckily for some people, if their collateral flow, so when their cholesterol builds up slowly and they exercise, it's typically in people that exercise, but it's kind of a little bit of luck of how your body works. When particularly your left circumflex or your RCA, if you shut this down, sometimes your body will take like this little vessel and it will force that blood force with exercise, because as you exercise, your arteries get bigger because you need more oxygen saturated blood to your muscles. And it will force these little arteries to get bigger. And it will get so much bigger that it will wrap around and connect with another artery to get the blood flow from it. So if we'll go to the next picture, because it typically happens on the RCA and it will collect, it will get to that next, it will get to the left circumflex. So typically collaterals happen on RCAs, the right coronary artery, and one of these vessels will be off down here towards the bottom. And you will see this vessel or one of these vessels continue to grow, and the blood flow for this area will actually come backwards, I don't know if I'm explaining that, and feed it from that right coronary artery. It is, again, typically, and it saves people's lives because they have collateral. Because that area that doesn't have the artery being fed to that muscle, that's where the muscle dies. So if you get a collateral building off there, then it's feeding the muscle and you don't die. So it's always really lucky for that patient if they have that in their lives. Does that make sense to you?
Does that show differently on the ECG?
It will just show up like an artery. Nope, it will show up. It will look different because we'll see it come in. It's usually typically smaller. And, let's see, it's usually typically smaller, so if I can get back. It'll be more squiggly like some of these. You can typically see a little bit more squiggly like that, but it will be coming, the blood flow, because as the dye shoots into the artery, it follows, as the heart beeps, it starts where the catheter ends, so the blood flow will start here, and you'll see it quickly flow to the end. So if you have collateral, it will still start here, but it might come here, and then you'll see it come up here to the back of the heart and feed that part of the heart. And then we're really happy. So I don't know if you want to review this case, or do you want me to review this case?
Yeah, go for it. Is this the one? Which one was this one?
This is July, the ones that the group came in and stayed in the lab with us.
Is this the 62-year-old?
52-year-old?
51?
52.
52. I'll let you do it.
So this is one I thought that it would be good to review with you guys.
Crew, wasn't it you? Yeah.
It was Leighton. Yeah, raise your hand if you were here. I had a little blonde. One of you guys was blonde. I can't remember doing CPR on him.
Oh, it was our student.
It was her. There you go. That's what I got. Well, welcome. So I was scrubbing this case here, and I have some of the times, which is kind of nice, and I do these on all of the hardtacks, so, and I give them to Jalen, so if you ever want to see them, and then we post them in the EMS room too. You can always look at them. There, you can see the call came in to you guys at 15:18 is when you arrived at the patient. I didn't put the time to call in, because you guys usually get there within 6 or 7 minutes typically. And I just go off of your report. So just make sure your report's accurate for me. And so it came in at 15:18. EMS arrival to the AKG was 11 minutes. I think this is one of the ones that you did on the way in. So this 52-year-old male, he had had chest pain for 30 minutes. He had had a previous heart attack about a year prior to that. And he obviously had been having some symptoms but knew it was bad. So he pulled into a gas station and he called you guys up and you guys arrived. Apparently, from what I hear, he was kind of slumped over. He was still talking. He handed a bystander a phone to call his wife. Does any of this sound familiar to you?
Yeah, he pulled into the gas station because he was having chest pain. He waited about 30 minutes before calling us. His wife was on the phone with him.
With him.
And then called into the gas station actually to have somebody come out, and then she also called 911 as well.
Okay. Thanks for that information. So he was obviously in distress. The patient was in distress at that point. You guys probably took a look at him and like, ooh, this is not looking so good, right? So you guys loaded him up as quickly as possible. The bystander, and they were getting some information on his history, on some of those things like that. I think in your report, he said something like, make sure my family knows I love them, right?
Yeah.
Which you hate kind of hearing those kinds of words, right? Because you're like, oh. And so like, even when I read it, I was like, oh. So he was loaded and the EKG was completed. That's what happened to that 11 minutes, is that you did it in the route. And once you got it done, it was transmitted and we had STEMI activation. You got there and we were setting our table up and ready to go. Our ER physician accompanied the patient to the cath lab. As we were getting the patient on the table, he became very anxious. And trying to kind of like climb off the table, and we were trying to hold the product, trying to hold him on the table. I was in this case, I was scrubbing. It was an anxious time. Did you guys feel that way?
Oh yeah, it's not.
It felt anxious, and it's kind of crazy because you can see our first medical contact to balloon was 58 minutes, which was great, and our door to balloon from the time you guys hit to reperfusion was fine. But it was an anxious, long wait. So my ED physician ended up having us call a cold blue and was determined and thought that he did indeed, which was verified later, that he went into pulmonary edema. And anytime a patient goes into pulmonary edema, that's very typical of how they react. And as they're starting to become closer to death, we can see that on the table sometimes. So I think it made us all feel a little anxious there. But the doctor decided, our cardiologist got stuck in traffic, so we were calling him and he was stuck in traffic. It felt long. It really wasn't as long as it felt, but it felt long. The patient began to desat quickly into the 70s. So at that point, we decided to intubate the patient. That started just about the same time as when the cardiologist come. Our cardiologist that was working the day is probably known to be the best in the valley. He is a great cardiologist, and you can ask any hospital and any rep in the valley. He's probably the best in the valley, and we are glad to have him on part of our team. If you can notice here, from the time you guys got it into the cath lab, the patient hit the door was 11 minutes. From the door to access was 30 minutes. And from access to reperfusion, this is where he really made it up, was 6 minutes. Average in the state is 21 minutes. And that's his technical finger skills. Unfortunately, this patient was intubated. He went into pulmonary edema. Even though he was 100% on our on our intubation and PEEP was high, we did not get his SATs above 80 throughout the procedure. I was most certainly worried at that point, just in seeing the continued SATs in the low 70s, even though we were on 100%. But we found reperfusion. After reperfusion, he went into some funky rhythms. We had to shock him. We had to do some things. Later that night, he returned to the cath lab for a pacemaker, so he came back into the cath lab. They put a temporary pacemaker in because he went into a 3rd-degree block. So they put a temporary pacemaker. He became stable. The next day, our intensivist felt like he had enough, very little brain anoxis injury. So he started to attempt to get him transferred out that night, actually, to the new. You didn't have any available beds. By morning, we found IMC to have a bed, and with the hopes that they would put ECMO in. They went in to the heart, and they went back, and that artery was re-occluded. They re-stented it and put ECMO in him, and then the next day, unfortunately, they did another EEG, and due to brain anoxic injury, they withdrew on this patient. I wanted to bring this up, not because we have so many good situations between you and us, but this was a very difficult situation. And I know whenever I have a very difficult situation, I am very 100% committed to the chest pain program, 100% committed to the lives of my chest pain patients and the outcomes that they reach. And so I look for what things could we have done better and what adjustments can we make. Did you guys have any thoughts on that?
I thought the innovation probably was a little late,
I
honestly.
felt like that too. I think that is, I'm so glad you brought that up because I actually brought that up and I have encouraged to go intubation sooner. Because I feel like we were behind the game of intubation. Agreed.
Hopefully would have eliminated him vomiting as much and the anxiety and things like that. It just seemed like that compounded fast.
Yeah. Yeah, I agree. I feel like intubation, and I'm really am going to encourage the doctors to intubate. Like again, we are a team, and they really take suggestions. So if you guys are in the room and you guys are thinking of something, like our doctors, we're a team. We're not. It's not just a doctor versus staff. It's a team effort. So if you guys see anything that you guys can see, please go ahead and ask us or whatever. You know, like hey, do you want to consider intubation? You know, because we are open to those. But I did identify anything else. Yeah, I felt like.
I'm surprised there wasn't a conversation about trying to get him on ECMO sooner.
Earlier, they did start ECMO that night. We no longer at Davis Hospital do ECMO. And so they did actually start that process as soon as they got to the ICU with the intensivist, but they did not have rooms available, but that's a good thought. Do you guys know what ECMO is?
Yes.
Okay.
Are we gonna get ECMO back?
I don't know. Like, that's a question for
Even if they could have cannulated him long enough to get him transferred somewhere to do the
Right.
long-term care.
and we've had really good success with ECMO and transporting, and I would think that somebody would take them with ECMO, but I think that's a great suggestion. And actually, we'll talk about this. This case will come up in a couple of our meetings, and you know, but we have not had those yet. But since I was coming, I wanted to talk about that. So I think that's a great thought. Any other thoughts?
Do you mind addressing, just so everybody's aware, like the time your doc has to report in, so
Okay, the time what?
that they have to, don't they have like a 30-minute time frame?
They do have a 30-minute time frame, and let's see, where was he? I don't think I put that. Do I have it in my notes?
No, you don't have any notes.
I'm pretty sure I'm pretty sure I had notes on that.
Actually, you've got a bunch of reports you backed up on, don't you?
So, that's a good thought. Like our docs from the time, along with the cath lab staff, all of us have, from the time that we get notified, we have 30 minutes till we arrive at the hospital there. And again, if we do not meet, that is a national standard. And if we do not make those times, then we have to have a reason and why to, and we have to have 80% compliance. Typically, we're there in 20 minutes.
And that's the time that we call it, right? So when you guys are in the field and you call us, you say, hey, we have a STEMI coming, you call that code STEMI and they're immediately on their way. So that's
Activating.
from the time that you guys tell us, they have that 30 minutes to get there. But normally it's within 20. That's why we want you guys to tell us as soon as possible.
That is one of the biggest advantages for you to call in or transmit and tell us that it's a STEMI, and get that transmitted so that we can get everybody going in on the road as fast as we can. All right, anything else on this? Like I said, it's, it's one of those that kind of hits your gut a little bit, hits your heart a little bit on those, because we would have liked to have seen a better outcome. He did have a previous heart attack. He did continue to have, not control his risk factors, but I would have projected him coming in and talking until he went into pulmonary flash pulmonary edema. I would have projected him to be one that was going to be making it through this procedure, which is always the worst surprise, So, here is, can you see that EKG? You guys had it out.
Yeah.
Can you find some elevation? I appreciate it, you guys, for the work you do. Appreciate it. Do you see any elevation in here?
Anterior side.
Anterior. So we're gonna be looking right down at that LAD to make sure that it happened there. So for this case scenario, like you said, we came in and we took the images. In this view, you can see where the stump is. Of course, the heart is beating, so this is the still picture, which is way easier, sir. But that is the stump. So this is the circ in this area, and this is the LAD. You can see after we stented it, that it reaches out down to the heart all the way, and this is the diagonal that's off of that there. This here is a picture of a STEMI that was on the circumflex here. So you can see here, this is where our occlusion is, and then you can see here, this is after extended. This would be somebody that would probably be even more symptomatic because those vessels are so big and fed so much of that heart there. Thought I'd talk about bundle branch blocks. What do you guys know about bundle branch blocks?
Delay in conduction.
That's a delay in conduction. Unfortunately, like I said here, 40 to 60% mortality if there's a brand new left bundle branch block. There's a 40% mortality. So we consider new left bundle branch blocks to be STEMIs because of the high mortality rate. So we always want to kind of go over. So the first thing you look for a bundle branch block is you look for a wide QRS. And if you guys also know, what else do you look for if you're looking for a bundle branch block besides a wide QRS? I'm always looking for, did you want to tell me?
B1.
In B1, that's exactly the lead. And typically in some lead you'll see those bunny ears, that's little two-pointed ears here. So, and I look at V1 to determine. How do you guys determine a left from a right bundle branch block? It's right bundle branch blocks. We don't have to do anything on you. You can know, just know it.
Turn signal back.
You can turn, halfway turn, 1/4, turn the EKG, and it will point left or right, the R wave. And so you can identify it that way. There's several ways. You can, yeah, that's probably the easiest though that I've heard, yeah.
Can you kind of talk about maybe interpreting STEMIs with bundle branch blocks? Because we had an instance recently where I called the STEMI and he kind of told me to throw the rules out. And the person was symptomatic as well. We had everything else kind of lining us up. But when I called the STEMI and it wasn't at your facility, but he told me, he's like, oh, he's got a bundle branch block, that throws everything out. And I get it, I'm not the best of paramedics, but is that really the case? That we
This is what I would say to you guys, is I have ED doctors coming into the cardiologists. So ED doctors see EKGs a lot, right? They're making a lot of decisions almost on a daily basis to have the cardiologist read an EKG that they're not quite sure about. So if you're not quite sure about it, I would say, hey, we think this is a STEMI, and then let them, be the winner or the loser. But I think that the biggest thing, and I don't know that I really have the answer for that, also in pacing,
Right, I've
We
always
can't-
been told you throw the rules out with the pacer.
you throw all the rules out in pacing. So if they are paced, I will never call a STEMI.
Right,
And if I were you guys and they're paced, I would say they're paced, so we want you to look at it. That's what I would say. Because my cardiologists say they're paced, it can't be a STEMI. That's what they say. So, but I really don't know the answer to that left bundle branch block unless it was just the looks of the morphology of the QRS.
because
That
to me,
they
if
were
you've got
identified.
elevation and contiguous leads,
You would think,
and you're
right?
symptomatic
And,
as well, right?
and they're symptomatic.
That's
I
the
would
key, is
think.
the symptomatic part.
Right.
I would
Something's
think.
causing a bundle branch, something's causing the symptomology.
I would think, and so I'm not able to really answer that question there for you. Dr. Nelson will be here, you can ask him, but I'm not sure, or I can ask my cardiologist when I get back and see if he has a good answer that I can have him tell you guys.
I've heard doctors in the ER be like, well, because you'll call it and be like, it's a left bundle branch. And they're like, oh. And I've always been told that if it's a left bundle, you treat it like a STEMI.
You treat it like STEMI, and if you don't have a previous EKG,
I feel like they would do.
only with new, if it's an established left bundle branch block, then we don't call a STEMI on it.
I've had it before, but so I've heard the same, but I don't know why they.
Yeah, yeah. I really don't know. So here's an example of that. You can see it's a wide QRS. You can see that the left is pointing down and the right is turning in, and you can see if you took that paper a quarter turn, that your R wave would be pointing right, and you can tell your R wave would be pointing left. So if you don't remember if it's up or down, you can always turn your EKG a quarter and it will point to it. So this one we wouldn't do anything about, and this one we would call a STEMI on it if they didn't have a previous known left bundle branch block. So looking at this, like Roseanne said, Roxanne? And what lead do we look in to see if it's a left or a right? V1. V1 is the lead that tells the bundle branch block. So on this one here, V1, which one is it, a left or a right? It's a left. It's that easy, right? It's white QRS, it's left bundle branch block. You can see the little bit of bunny ears right there to help you identify that. There's some bunny ears right there too. You can help identify that, but it's a white QRS. Here's another case example. Here's a 56-year-old male. He arrived in the Roy at 6:24. He had had chest pain for 2 hours. We made that 10-minute EKG time at 6:32. At 6:45, you guys were transported to Davis. I don't know if it's Layton. I'd say UMass in general. I don't know if it was Layton. Cath lab was already present on site. We had 100% occluded RCA, which was stented here. Here's the EKG, which falls true. You can see there was elevation in what leads? 2-3 in AVF. So he can, here we have an angiogram. Can you push play on that? So the point up there is the catheter where we're going to shoot the dye into the coronary artery here. This is also the catheter that is just coming up and around. Obviously we went right there. And you can see that's how much time we have to look at that. And that wasn't clear because it's very short, but that's how fast we have to look at it. And we're, yep, we're 100% occluded in the proximal RCA. And we would go, so that was at 7:16. And you can see we started this at 06:24. So approximately 45, 50 minutes there. So I wanted to show you a picture. So right here, it's again visual. We drop a line in so we can establish the artery, and sometimes it can be really tricky. Again, it's the finesse of the physician to be able to get that line out to follow the artery without dissecting it. This right here is the balloon. The inflation is between the two dots. So they visually just see where the blockage was and then put the balloon up. The balloon up is 3 times the amount of pressure of a tire. So you can see its plaque is pretty tough. It's hard to get through to crack in there. The next one, if you'll push play, you can see, oh, nope, that's not a play one. That's after the balloon. We ballooned right here. And now this would be a reperfusion time because we have reperfused, but you can still see that we have about a 99% blockage here. And then you can see right here also we have some disease that we're concerned about, and maybe even down here there. So after this, after we get the reperfusion and the balloon, this is when we would go in with the stent, and the stent would push out the disease the rest of the way. And then if you want to just push play for me, then we'll have the final picture there again. It's just a quick little picture. And you can see after we put the stent in that you can see that we had just great results there. I don't know, push or play one more time. Also at the beginning of the you can see we can, like, if we don't know they have a stent previously, but you can kind of see the wire outline post stent. That's how we know if somebody doesn't, like, sometimes we don't get to know if they have a stent. The stents never go away. You can put a stent inside a stent if that's your last choice. And as years have come by in the last 5 years, we're now starting to laser inside of the stent, and we're starting to also do lithotripsy inside stents to get further disease built up and taken care of there.
So, back in the old days,
Uh-huh.
there used to be kind of a recognized lifespan of stents. So if somebody told me they'd been stented about 10 years ago, I'd be like, oh, well, you're probably in that window.
Right.
What's kind of the
We're
belief
saying
now?
we're saying about 20, so about double that, and
Okay.
that's because we've now got drug-eluted stents, DES stents, and so we put they have drugs on the stents that help
Right.
fight that cholesterol right inside that area. So about 20 years is about where we're at, so double that. Stents only came around in the mid-1980s. Before that, everybody pretty much had to go to bypass. So we're starting to see 40 years. You know, gosh, if you saw somebody that was done in the 80s and they came back still, then you're like, oh, that's amazing, you know, but not typically. Not typically anymore. So, and you can see here we have ST elevation in V3. So I look at V3, I know V4s ideally. So you can see it's probably an LAD. This is a 71-year-old male. He walked in with chest pain around 11 o'clock. He did have shortness of breath and diaphoresis. He's non-compliant with his medication and is a smoker. He was activated at 12:59. He says his chest pain's a 4 over 10, but it kind of felt like everyday usual chest pain. He was alert and talking. We had arterial access at 1325. During the diagnostic pictures, the patient went into VFib of wrist. So we shocked 3 times CPR and cold blue was called. He was intubated with short bouts of CPR all the way through all of the procedure. He had his proximal LAD was occluded. And the reason why I did this picture is this was our first image that we got with our catheter. So our catheter ends here. And this first image, while you can see a ton of disease, like that's pretty narrow, nothing is super occluded here, you know, you still have about 40-50%. And we see these vessels here, which at this point we'd have to assume is another artery. So then we took the second picture, so the C-arm has moved around, and then all of a sudden you see that right there. And remind you, it's like in a heartbeat. So it's really good eyes to pick that little nub out, or not to just think there's nothing that exists there. But sure shooting, that was the LAD right there. We didn't know that till we saw that. This guy's probably from his smoking and his continued everyday usual chest pain, had disease throughout the entire LAD. It was amazing work by our cardiologist, really. But this whole thing is now stented because the whole thing was ratty with hardly any flow. I don't know how this guy lived, but he did. And we got really good results. But the biggest thing I wanted to just show you is, like, it's not always easy to find. Like, it's just by eyesight on a heartbeat, you know, to where that coronary. So super impressed with our cardiologists for the work, you know, all around the world that they do. Our average time for Jordan is 54 minutes. And that's when they come in, walk in. And then when we use you as an EMIS, then our average time is 71 minutes. Those are well below our national averages. And we're typically top 1, top 2 in the state. Typically top 1 in the state of getting that. So if you can't do anything else, you can always put lavender on their feet. I guess, I don't know. Obviously, we do appreciate any other questions that you have or things that I can answer or not answer.
Well, that was awesome. Thank you.
You're welcome. I most certainly appreciate your time and letting me come in and talk to you. We do appreciate everything you guys do with us and feel like we have a good relationship. And I really did appreciate, you know, you guys coming into the lab and understand it. You're welcome anytime. And if you have questions, you can either reach out to Jillian back in the back. She's always great to be the liaison and get you any information if you didn't understand something or you wondered how the patient was doing or anything else. You're welcome to reach out to her.
I have a
Thanks.
question
You
for
bet.
you.
Yeah.
How do you guys tolerate Todd?
That is a good question because on Sunday I am like, I'm done with him. You know, I'm done.
Good.
So,
He can be a grab.
yeah, I can do that. He has a lot of knowledge, so we appreciate that.
That's for sure. Good guy.
Good guy, yeah. What's that? Yeah. If there's a left on the right side. And I was like, should I pull it up and have you guys review that? So yes, the doctor. The doctor. Is it beneficial? For everybody. Yeah. If you're aware of it, you can pull it up on your phone or whatever. But that is what we use to use the left on the right. So, yeah. we don't use that.
Thank you, that was awesome.
Oh, thank you, you guys.
And if that's the case, it puts me in good company. Ross, did I see you put everybody in?
And then I can skip two. I can skip two questions. Hey, I picked up. She wanted to work my Saturday. And you wanted Saturday instead,
Did Sharon get a suspension?
So I was gonna see Bride.
Really?
Okay.
You should. I was like,
I know. I love you.
Where is that one? Where's that, who was the girl that was sitting here? That was one, not one case? Right here? No, she was one back, right here, I think.
she's on the call.
Okay. Let her know, if you guys don't mind, like, that he was wrong on that case, and he does go to review it.
I swear to
Just like, we don't want to just, like, you know, let her know that. So.
How's it going? Good. You? What I'm talking about.
So, Brady, come here.
Oh, yeah. No.
Here.
That's awesome.
So, I don't know.
Rock, did you enter us in? Did I see up there?
Yes.
Thank you.
That works, right?
We love it when you